Beginning of this, we're going to talk about some of the forms that we've been using recently, and to tell you about that, I've asked George to come up here.
This is the confirmation form. Whenever you send in a referral, within 24 hours, we try to get at least a form like this back into your office, so you know exactly when the patient will be seen and by whom. This is the schedule for every patient, the projected schedule for the week. Now, why is this so important? Nowadays, with Medicare, we need to be very careful when we do our visits and when we do our reevaluations. That is especially before the threshold comes close. So we need to be around the 13th visit that we do a reevaluation. If there are more than one discipline in, they need to share it between the 11th and the 13th. Same goes for the 20 visit threshold, that we need to do it between the 17th and 19th visit. Okay, so by giving you a weekly report that basically states when we're going to see your patients, you can also talk to your other disciplines that might not be provided throughout. In addition to that, it's also a good way to inform your nurses. Say, well, that physical therapist is going out on Tuesday, the occupational therapist is going out on Wednesday. Can you go on Thursday, right? So, yeah, for instance, for your blood pressure, if you want to monitor that on a regular basis, doesn't make much sense. If PT just did it, the nurse comes in. Better to do it on a date that there is no service provided. And we have here the daily report. That is actually the visit that was performed. All right, so you get a lot of reports over time. But at least I hope that you can appreciate it in that sense, that you constantly know what's going on with that patient. No more reports. Yes, sir. All right, now everybody's probably familiar with the rehab folder already. We have implemented this because of the difficulty with Medicare patients that particular reevaluation needs to be done before the threshold, before the 14th and the 20th. Now, since we don't provide all the services, let's say that we provide PT services, but the OT services are provided by another company. Instruct these companies also to start using this rehab folder. What it basically does, any time an OT, a PT, or a speech therapist comes in, they basically need to write down their name, the date, and their title. By doing so, we can a running total of the visits that have been done. And then we get alerted also timely when we need to do our reevaluations. This is basically the biggest problem that we have to cope with. Let's say we have speech, occupational therapy, and physical therapy in. Let's say the speech therapist at the 11th visit does a reevaluation. That was correct. Now the OT goes in, does a reevaluation on the 12th visit. They did a good job too. The PT, however, wanted to go that same afternoon and the patient canceled. Said, well, I already had OT today, I don't want to be seen, come back tomorrow. However, the speech therapist beat the PT to the visit and came in the morning and the PT came in the afternoon. That means the speech therapist did the 13th visit and the PT is basically out. They're not allowed to continue services because you need to make a reevaluation before the threshold, which is 14. So visit 14 can never be done unless you have done a reevaluation time. Okay. That is one folder. Then we added another folder. It's actually I'm sorry, I said a folder. it's a form. Okay, that's for fall prevention and equipment recommendation. Now, we leave a copy of the folder in the patient's home, and we send you the original. So you know exactly what kind of equipment that patient has, and also what kind of adjustments we have proposed and have done, because it all needs to be on that particular form, right? So you always have a running list of what has been done. You cannot say, well, oh, you wrote down this, but you never documented it that you actually did. It will be there. Joey will be talking extensively, obviously, about outcomes. Now, for Medicare, we need to start showing that we make progress, and within a certain time frame. Now, thus far, until the software comes out, it is hopefully in 2 weeks, we're ready to go for all new patients to use the software. But until then, we have another form that's a weekly report. Now, this weekly report will be done by every therapist every week. And by doing so, it shows constantly what kind of progress has been made so far. Because that's what they're going to scrutinize. If you do a visit that looks very similar to another visit, and there's not a whole lot of difference, they might just cut one of the visit and say, well, it was not needed, right? So that's why we have this form that basically shows what kind of progress has been made in what time frame, right? So every week, together with the paperwork, you will get this form. However, as soon as we start with the software, then we do not need this particular form anymore, because then every visit will make a comparison between the evaluation and the current status of the patient. Okay. That said, are there any questions concerning these particular forms? Everything clear? Everything is in your package? I'll give it back to Joe.
All right. By the way, one of the things that I failed to mention earlier, there will be time set aside at the very end of the meeting to answer some of your questions. Certainly we can do it in a group setting, but also we're going to stay behind. We've got the room for, I think, until like 5 o'clock. So if there are any individual concerns that you may have, we'll be willing to stay around and answer those questions for you. I know we gave this meeting, or we gave a meeting about, what, 2-3 months ago? Has it been that long? About 3 months ago. And there were a lot of reasons why we wanted to give that meeting. One of the things that happened as a result of it was actually a pleasant surprise. I've noticed as a result of that meeting that our dialogue, our conversations with you guys have been a lot more pleasant. We no longer were accusing and pointing fingers at each other, but we realized there was a problem to be solved, and I noticed that we were more in the mode of probably solving those problems rather than proving who was right. And I think that's what we need to go towards. We're in this together. We're not trying to do this alone. There has to be teamwork on every side in order for us to get through the changes. I also was accused of being a little bit more on the doom and gloom side. I realized that back then I played the role of Paul Revere. The British are coming. The reforms are coming. But this time I'm really excited about the things that we're about to present. The invitation that I gave you, that we sent you about 2 weeks ago, I told you that I attended a seminar about 2 months ago by this gentleman. By this gentleman, Arnie Cisneros. Arnie is one of the leading voice when it comes to the reforms of home care. Arnie is a physical therapist, and when I heard him in Chicago and he gave us some of that information, I immediately, while I was sitting in that classroom, I said, I've got to present this to the group in Houston. Knowing that, after the meeting, I went directly to him and I said, look, this is my intention. We're going to give your information, some of the things that we learned from you, we're going to give it to the agencies in Houston. And I asked him, do you have a problem with that? Because he does this for a living. And he said, absolutely not. We've got to change how home care is being delivered in all of the United States. I can only hit one city at one time. Actually, 2 weeks ago, he was for some reason in Ontario, Canada. I don't know why he would be needed there, but he was there. But this time, I think this week, he's in Virginia. He said, please pass that information along. Then he goes, but I have one favor to ask you. And I said, what is it? I'll do it. I'll do anything. He goes, please tell them about my website, Home Health Strategic Management. Please have them sign up for my free newsletter. I've been using this newsletter for several months now. It gives you updates of what's happening. In fact, one of the handouts, it talks about the surge. That was from the newsletter last week. This week, he talks about where he's going to be and what seminars he's delivering. It may be, the subjects may be pertinent for what you guys are going through. If so, sign up for it. They're not very expensive. You may have to travel. I didn't like the fact that I had to go to Chicago without my wife. It's the first time in 20 years we've been separated. But, yeah, but it was well worth it. So anyway, please sign up for his newsletter. All right. So one of the things that I learned from him was what was the final, or what were the final changes for 2011. Okay, these are the final changes. Is everybody aware of PAYCOS? Yes. Please say yes. Yes. Okay, good. So you know that with PAYCOS there are two phases. The good thing, the phase that we're in right now, if you're not enrolled yet, I don't know why this is not working. If you're not enrolled yet, you will still get reimbursed for the visits that you're doing. The bad thing is that this first phase ends in July 1. As of July 1, if you're still not enrolled, whatever services that you provide will not be reimbursed, will be denied. So you better sign up. I think, Charlotte, is it $500, $505 to enroll? How much is it to enroll, to be enrolled in this PAYCOS? I think it's about $505. Folks, please look it up. You got to sign up for it. Please check. Okay, all right. Please check. Also, every doctor that you guys use, okay, you know that the doctors that you use has got to have their MPI number. Okay? If you see a patient and those doctors don't have their MPI number, those claims will be denied. Okay? All right. The therapy coverage requirements. We talked about that last time. We're not going to talk about that this time. We'll briefly touch on the visit reassessment rules later, but we're not going to spend time on that. Neither will we spend time on the G codes. You guys should know about the G codes by now. Okay? Employee screening. Are you guys required to do drug tests on all your employees? I was about to say, if you did, I haven't been drug tested, and I see all your patients. So no. But you are required to do a criminal screening, yes. Right? Okay. Do you guys check professional licensure on all your staff? Yes. I hear yes. Why is it that some of the providers of rehab are not licensed?
You said on our staff.
No, yeah. On your staff, but including in your staff are everybody that's seeing patients for you guys. Even if I were you, even contracts, we check it, but if I were you, I'd check what we check. It's honestly, I mean, you could be paying us thousands of dollars, and at the very end, you're denied. Because this is the reality of things. I do a lot of interviews. And there are some folks that I'll interview and they'll say, why do you need to meet me? Because I'll ask them, I need to meet you, you know, we need to meet face to face, got to know if it's going to be a match. And the response I get is, well, the other agencies don't let me do that, don't require me. In fact, I get the call, I get home, I get the call, and they say, well, if you're willing to see it, I can go ahead and fax you the referral now, without doing any checks. Be careful, folks. You will be denied for those visits if those therapists are not licensed, okay? All right. Has everybody heard of the Community Transition Program? I'm going to change, I don't have much of a pointer, laser here. I'm going to change this. Anyway, the Community Transition Program, I read this on the Eli Healthcare Week. What this is that CMS has allotted $1 billion to decrease the rehospitalization rate. People that are interested in doing research and studies on how to decrease the rehospitalization rate will have access to $1 billion. This is community-based, which means you guys can be part of it. They're taking applications now. Okay, this is money that's out there to be had. And believe me, the hospitals are taking advantage of this. But under the rules, you guys have access to it too. Okay, $1 billion. All right, MedPAC, the Medicare Payment Advisory Commission. This is the advisory committee to CMS. These are the proposals that they have. They just met at the beginning of the year, and their latest proposals are the following. By the way, when MedPAC proposes things to CMS, it usually happens. Okay, so this is what they're proposing: equal access for all patients. That means every patient in outlier areas, every patient in every socioeconomic areas, every type of patient, they want a standardized care for every patient. Which means that we are to avoid doing over and underutilization of service. What I've noticed is that we're starting to get better with controlling the overutilization, but I'm also seeing folks that are just going on the other end, the deep end of it. No, you can't provide OT right now. It has to wait until the next cert period when the PT is done. It doesn't make sense. That is underutilization. If OT is needed for that cert period, you better ask for it then. Okay. This you guys should like. Increase profitability for agencies with outcome-based practice. They are incentivizing outcomes. They are not going to pay for visits. They are paying for performance. Forget about, you got to go out there, you got to make sure you do those visits. If no function, like George said earlier, if no function was shown for that visit, or if no skill was shown for that visit, it's not going to be paid for. They're paying for performance. Again, these are proposals. You guys ought to like this one too. They're requesting that there be an increase of 25% reimbursement without therapy. Yeah, I heard a yay. That's good for you guys. We're happy for you guys. We're not happy about the second one, a decrease with us involved. Not so happy about that. Again, these are proposals, but again, you guys have to start getting geared for these things that may possibly happen. So as we talked about what the final 2011 reforms were, now we have to start looking ahead what the 2012 PPS reforms proposals are. So the second part are not reforms. The first part, again, outcomes, reimbursement based on outcomes. And not only that, but higher reimbursement for shorter, more efficient care, which produces those outcomes. Okay? You know how things are right now, the more visits you make, the more money you make? That graph is going to be inverted. The better care you do, you're going to get more money for. The more care you provide, you're going to get less money for. Okay? Start thinking along those lines. The copay for non-acute cases. You should all say yuck with this. What they're suggesting is that those patients who are not acute cases, have not come from the hospital, for every cert period, they're going to be required to pay $105. Imagine that. So what does that mean? Well, your total number of visits are probably going to go down, which means that your total number of cases will go down, but it also means that your total number of denials will go down, because the denials are happening from these non-acute cases for the most part, which means that you don't have to provide free labor. You guys, the administrators, are paying staff, nursing staff, therapy staff, to do visits for you that you may not get reimbursed for anyway. This will cut back on that. Personally, I don't know if I like it. I am kind of leery about it. Okay, it'll certainly reduce the number of patients that we see, but it also screens those patients. The patients that we ought to get, or we will be getting, will probably qualify for therapy, for rehab. Okay? Post-acute bundling. This is another one of those yuck things. We shouldn't be too happy about this. What this means is that CMS, here's a proposal, CMS is going to give one lump sum. If a patient goes into the hospital, they're going to give the hospital a certain amount of money to care for that patient for that onset all throughout the care. From if they have to go from the hospital to the rehab setting, rehab to LTAC to home, and every equipment that's provided for that patient will come from that one lump sum that was given to the hospitals. What does that mean for you guys? You're going to have hospitals, exactly. Well, you're going to have hospitals. If this passes, this post-acute bundling, if this passes, you're going to have hospitals setting up home health agencies. And their patients will be funneled through their home health agency. Okay? All right. The accountable care organization, the way it differs from post-acute bundling is that it doesn't limit it to hospitals. It limits, basically you're going to have a union of healthcare providers. It probably will look like a hospital with a home health agency, with a DME, with a prosthetics orthotics company, forming a union to manage that money that Medicare gives to the ACOs. Okay? Again, these are proposals, but just to give you an idea the way CMS is thinking. The bottom part. This gives you a visual of how the reforms are making our visits lower, making our visits trend down. Before PPS, the average rehab visits was 18. In 2007, it went down to 11. That was a big jump. In 7 years, went down to 11. Where we are right now, national average is 8.9, and in 2013, they're projecting it to be 6.7. Keeps going down, okay? And that's why the things that we're going to talk about later, it's going to be critical to start thinking or get us to this number. Here's the problem though, South Texas, we're at 11 visits. We're operating under 2007 numbers. In comparison, Oregon are seeing their patients for 7 visits per case. So you have Medicare asking, what is South Texas doing? What is South Texas doing that Oregon is not? Or really, what is Oregon doing that South Texas is not? And we'll talk about that later. The national average are 14 visits or more, cross out less, or more. Made a mistake, that could have been problematic. 14 visits or more, 15% of cases. What does your agency's numbers tell you? Are your visits, rehab visits, 14 visits or more, 15%, or is it over that? It's probably over. And that's what's contributing to this number of South Texas being 11 visits. Lastly, over 10 years, they've done studies, shows that patients who are seen for longer periods don't get better. Goodness gracious. Why? The reason why? Patients who are seen from cert period to cert period to cert period are patients that are, one, incompliant to begin with. They're not doing their home exercise program. They're not doing the nursing care, what you guys taught them. They're not doing anything they're supposed to be doing. And or, the other factor that contributes to this is you have clinicians that are seeing those patients that are coddling them. They're not teaching them. That's why this figure is very important. That's why they're wanting us to focus on outcomes. Okay? All right. Comparison reimbursement. You guys are aware of this graph, hopefully. I don't know if you've seen it in a graph form, but you should be aware of this graph. CMS made an amendment on their reimbursement schedule. And this is what it looks like. These are rehab visits on the bottom. Of course, the amount of rehab reimbursement going vertical. From 0 to 5, you're paid, would that be like around $1,400, $1,300? Is that about right? Close. 6 visits, less than $2,000, right under $2,000. 7 to 9, around $2,400, $2,500. 10, and it keeps going. When I first saw this graph, I thought it was interesting, the relationship from one bar to the next, how it's almost a straight line. Okay, what does that tell me? Is that the per visit rate, per visit reimbursement is about the same. What does that tell me? I had to start asking, why is it that some folks are insisting us only to do 14 visits? It doesn't make sense. It doesn't make sense. It didn't make sense until I started studying the surge in the OBQI. We'll address that later. But as long as we stay on the low end of each graph, that left side of the corner, the per visit rate should be about the same. Okay? Maybe a difference of, less than $100, but it'll be close. All right. Hospital versus home health. Most of you know that OASIS data collection began in 1999. What many of you don't know is that in 1987, the Omnibus Budget Reconciliation Act was passed. What that act stressed was that there should be outcomes for home health. This took place in 1987. Who's been around since 1987? Who's been doing clinical work? Okay, who's worked in a hospital around that time? Okay. When did the DRGs come in? About the same time, right? What happened when they started making changes, the reforms for the hospitals, they were already looking ahead of what they were going to do for the hospitals, for the rehab, for the LTAC, which used to be called subacute, I think, for home health. They were wanting us to start thinking along the lines of outcomes in 1987. Now, I remember when the hospitals were going through this, they were like, oh no, we're gonna die. There's no way we can operate like this. We're gonna all go out of business. Do you see that happening right now? Really? Some of them who are not following the rules. But the ones who have developed programs, in my part of town, not too far from here, there are at least 5 new hospitals that have popped up. Almost within like a 5-mile radius, brand spanking new, incredible looking edifices. How are they paying for that? They survived. They did well, okay? So they want us to start mirroring, in home health, they want us to start copying and mimicking what happens in the hospital. So this slide, we analyze what happens in the hospital from admission all the way to discharge. In the hospital, what you have is a lot of communication from the get-go. What you have is a clinician that triages the patient, looks at the patient, looks at all of the medical records of the patient, gets the doctor's orders, comes up with a plan, okay? And then gets that information to all the pertinent disciplines that will be following that patient. When I used to work in a hospital, before I saw a patient, I had their medical chart in front of me. I knew everything that was going on with that patient. In home health, do we have that? No. What we have is, look, this is a referral, the typical referral that we get. Patient has high blood pressure. And we go over there, and this, honestly, folks, this really happened to me. I see the patient, and the patient, I think the diagnosis was, it was high blood pressure. I put my hand on the patient's back, and I hear a clicking every time. Every time they breathe in, I hear clicking. They exhaled out, I heard a clicking. And so I reported it to the agency, and they said, the nurse goes, I noticed that too. I didn't know what it was. I noticed it too. I said, x-ray, you got an x-ray. She had a fracture, a displaced rib, that was touching the rib. If I would have done care on that patient, we got a ruptured lung. That's the problem that we are confronted with as frontline clinicians, is that we don't have enough information to see your patients properly. If we had all the proper information on that patient, we can treat them quicker and we can treat them better. That's what they're doing in the hospitals. Okay? And also in the hospital, when they set goals as a group. They don't set, the PT doesn't set a specific goal for themselves and OT and nursing. They come together as a group. All right? Next, delivery of care. Okay, so we're in the caring process, the providing care process. In the hospital setting, you have weekly meetings. You have discharge planning right at the very beginning. You have daily rounds. There's always communication about that patient. Is that happening in home health? Not at all. The QA, there's always management of the services. Every time a visit is done, that visit is assessed to see if it stood up to the plan of care that was set at the very beginning. Then you have reassessment protocols. At the reassessment protocols, you review and you reset the goals. And when you get to the reassessment, there should be no surprises. I mean, everything that needs to be discussed should already been discussed. Everybody should know, okay, we're ready to discharge the patient, and no, we need to go ahead and ask for an extension. These are happening in the hospital. But what I find most problematic is the discharge, how we do discharges in the home health. In the hospital, there is no certification period factor. Why is it, by the way, that when we see a patient and we say, we're there for 60 days, after everything is done, after all goals are met, we still have to go all the way to the end of the cert period? I know not everybody's doing that, but there's still a lot of people that go all the way to the cert period and magically something happens on the 60th day that says, okay, we can go ahead and discharge the patient. Surveyor looks at that and he goes, okay, yeah, something's not right here. There are no cert period factor in the hospital. When the patient meets their goals, or when the services are such that they can no longer serve the patient well, the patient is discharged. In home health, this discharge is influenced by the doctors, by the patient. Please don't discharge me yet. I need you. I don't have anybody to talk to. All right? Who's gonna bathe me? All right? Or actually, in our area, the discharge is dictated by the industry. I mean, if the majority of us are practicing the same way and not discharging our patients the right way, then you have a patient that will go they're PEP'd from one agency to the next, to the next, to the next, and you don't want to lose your patients, so you hang on to them and do the things that you're not supposed to be doing. That's got to change, okay? Let's see, managing, we'll talk about the OBQI meeting. And when the patient is first seen upon admission, there is a time frame that's set. Not this nebulous number, oh, we'll discharge you whenever. A time frame is set. I have a good example of this. About 2 months ago, Chris and I went to New Orleans for a vacation. On day 2, she suffers a gallbladder problem. By day 3, she's got the old style removal of the gallbladder. I forget what you call it. So, of course, immediately I speak to the doc, said, Doc, I was about to say, when can I go home? I said, Doc, is she going to be okay? Not really. I said, when can I go home? And then he goes, whenever she meets certain markers, health markers, that's when she can go home, but no later than a week from now. So every day I said, Doc, can we go home now? No, not yet. She's got to meet this marker. Next day, same thing. By Wednesday, he said, you know what? She's met all her markers. You can go home now. I didn't say, no, I want to stay a little longer. I like the pudding here. No, he said, no, she's met the markers, go ahead and go home. And that's the way it should be in home health, but it's not happening that way. All right, so as we're treating the patients, there are tips that we should follow when it comes to documentation. At evaluation, after identifying the functional deficits, make sure you also establish the contributing factors to that deficit. It'll look like this. If I find a patient that has issues with ambulation, I find that their quad strength is weak, then I know I have to continue dealing with that quad strength to improve their ambulation. Every note, and it says here on the next one, every note, you should see that I am addressing increasing quad strength to improve the gait. If you don't see that, then there's a problem with that note. You guys get that? You understand? Okay, good. All right. Upon evaluation, you should go ahead and tell the patient and the family exactly what's going to happen with that episode. Mr. Smith, what's going to happen is this. Your quad strength is really weak, but I believe that I can get it done. I can get you strong enough so that you can be a safe ambulator in 3 weeks. Okay? And I know you want to be able to walk into the bathroom. So we're going to make sure that you can walk. How far is it from your bedroom to your bathroom? 50 feet? I can make sure that you can walk 50 feet in 3 weeks. Okay? And I know you want to be able to take a bath when you get there. So I'll go ahead and ask for an occupational therapy consult. Okay? That's the way it should work. All right. We already went to, of course, the things that you do, you've got to document completely and accurately. The last time we gave a presentation, I said that Medicare doesn't care if you ambulate the patient past 125 feet. That's no longer true. It's now 50 feet. 50 feet. If you're not working on quality of ambulation beyond 50 feet, they don't care. So if you have a patient that needs to go, like say 75 feet to the dining room, if they're in a personal care home or if they're in an assisted living facility, then you can, I know this is a stupid game, believe me, I understand that. When I see this, I just cringe. You can ambulate them 50 feet, working on the quality of gait, working on safety, and then stop them. Hey, how you doing? You doing okay? Great. Okay, and then continue walking. You're following that rule of 50 feet. Yes, ma'am.
One of the reasons that I see when it comes to home health agency doing the documentation is when an RN admits a patient, and the only thing that they will say is that there is a muscle weakness, not as specific as what you're telling. So we want to teach our RN admission to see all of those specifics that you're telling us.
Thanks, Ray. I appreciate you bringing that up because we are actually going to talk about that during the surge. Absolutely. That's very important. There needs to be a connect from what you guys see at admit and to what we see when we do an evaluation. And we'll talk about that. That's one of the things that we're going to talk about. All right. And of course, when you develop plans of care, it has to be outcome-based. All right. We're going to touch on the reassessment visit points, 11th to 13th and 17th to 19th. When you guys review those reassessments, you have to look for this. Is it confirming or establishing the effectiveness of the plan of care? Okay? It has to confirm or establish that. If you don't see a connection, if they just went out there just to go out there and they don't address, if the therapist does not address the goals and how the patient is responding to the goals, then it really was not a reassessment visit point. It doesn't follow the requirement that CMS has set for you. At that time, you have to conduct those standardized tests. They really should be conducted all throughout the care plan, but at the very least, from evaluation, then reassessment, they have to be done. Okay? This last one, I mean the second to the last one. If the reassessment is done only to justify the threshold, goodness gracious, we have to discharge the patient. If I write an initial evaluation and I do it 2 week 7, and I don't do that anymore, but this you'll see what I mean. If I write 2 week 7, and the assistant says, okay, we're at the 13th visit, can you do the reassessment? Sure, I do the reassessment only so she can do the 14th. The question that would be, what can she do as a PTA that I can't do as someone who supposedly has more knowledge on the 13th visit, right? I have to discharge the patient. So I understand that the reimbursement, going back to the graph, I understand that reimbursement goes down. But that 14th visit is going to be surveyed anyway. It's going to be denied. So we have to let him go. Okay? Now, it could be at that point that the patient may need some more time. We'll do the reassessment and determine if we can progress the patient even further. Functionally. Okay? All right, of course, you DC the patient, and the patient goals are met. The clinical management systems for 2011. This is where we're going to spend the most time on. Who here conducts a total OBQI process? All right. Who knows what OBQI stands for? Okay, I see a couple of hands. Outcome-based quality improvement. Exactly. All right. Who knows that there actually exists 4 OBQI manuals written by CMS? Okay, then the last question I have for you is, if it's so important for CMS to use lots of resources, time, people, to develop, this is just one of them. Okay, this is just one of them. To develop 4 manuals, do you think it's important to them that we follow their program? Absolutely, especially when it's called outcome-based. Okay, all right. Well, the Service Utilization Review, the SURGE, is a Arnie Cisneros created process. I think you guys saw the handouts. It's in your packet. The history behind the SURGE. Folks, this works. People around the country is using this. Arnie was very innovative in creating this. We're going to talk more about that. We're going to workshop it today. You'll see, as we discovered as a group how well it works, it blew us away. Actually, this is one of the reasons why we had to do this seminar, is to tell you guys how you can save money and provide better care. And also defend yourself against denials. Everything that you possibly want in operating a home health agency. Outcome-based quality improvements. What are outcomes? The definitions are there. They're health status changes between 2 or more time points. They can occur positively. Hopefully we're part of that. Negatively. Hopefully you're not part of that. Or neutral. It doesn't matter if you were there or not. They can occur as a result of our intervention. We're needed for that. Or sometimes they can occur as a result of just a natural progression of the disease. Last time we talked about the non-reimbursable visits. What did we call that again? The maintenance. Huh? Yeah, restorative care. No, it's not that. It was non-covered transient decline. We talked about the non-covered transient decline. What that means is patients may have gone to the hospital, may have declined a little bit, okay? But because they go home and they start just moving around, they're going to improve without us. That's what natural progression of the disease or disorder is, okay? Outcomes are important because we can critique the care that we provided to our patient. It actually tells us, were you effective? Did you have a role with that patient? And when we focus on outcomes, patients improve. This should be the reason why we're doing this. Our patients improve. Who gets the reports yearly? Does everybody get outcome reports here? Who does not get an outcome report? Raise your hand. Okay, so everybody gets one. And you know there are 4 reports from CMS. Does everybody get 4 reports from CMS? Okay, if you don't, you have to call CMS. They are the Agency Patient-Related Characteristic Report, used to be called the Case Mix Report, the Potentially Avoidable Event Report, used to be called the Adverse Event Report, the Process Quality Measure Report, which just began in 2010, and what we're going to talk about today is the OBQI Outcome Report. These reports, these reports, it's like your report card. It compares your report, compares your performance from this year to the last, right? It also compares your performance against the national benchmark. How are you performing against other agencies like you? Yes, ma'am.
Joey, those, just in case they don't understand, that's the Casper.
Yeah, okay, the Casper.
ASPR, they
Thank you.
really know it by that.
Casper. Everybody's getting Casper, okay? Yes? Good. Thank you, Shala. Okay. So, the survival, your survival, our survival as as rehab companies depends on us producing outcomes. All right. I thought it was interesting that I should get quotes directly from the OBQI Implementation Improvement Manual. You're going to find this interesting. The purpose of OBQI is to improve patient outcomes, not a surprise. The primary purpose of home care is to help patients achieve outcomes. It is not as a sitting service. I was about to say babysitting. It's not a sitting service. It's not a bathing service. We are there to help patients achieve outcomes. Decisions, therefore, within the agency should focus on how best to provide care as a result of collecting information and monitoring outcomes. I like this one. Enormous opportunities exist for agencies that utilize outcome and process quality information. Enormous opportunities. There are people who are seeing less patients that are making more money than large corporations that are doing it the wrong way because they're focusing on outcomes. Go all the way to the very bottom. It is the outcome enhancement activities, and this is what we're going to be doing today. The outcome enhancement activities that allow an agency to make changes in clinical actions that will lead to improved patient outcomes. If the agency carefully implements the steps in this process, your report card next year will get better. You have to implement the steps. All right, I'm kind of like a visual guy, so I thought I'd put this up for you. If you look at it this way, of course the OASIS is just collecting data, nothing to it. All it is data. And your report card is based on your OASIS, okay, and your performance. Once you have that data, once you have your report card, you have to investigate, identify, and address the problem area for your company, for your agency. Then managing the process means that you gotta start investigating what processes, what practices do we have in our agency that's causing those negative reports, or even you can focus on positive reports. That's okay too. But what processes do we have in place that's producing the result that we like or don't like? And you manage your resources. Do I have the right staff to be able to do the things that I want to do? And most of you here are administrators. Am I getting the equipment in a timely manner? I'm glad that Centers for Mobility is here. Like I said earlier, I am starting to use them a lot more because my patients are getting better, faster, and safer by just me ordering a simple piece of equipment. Managing your resources. Are you doing that correctly? If you follow from top to bottom, this is where you end up. Cost-effective care. This is where we all need to be anyway. To make money, it's okay to make money, we're business people, okay? But to provide care, to provide quality care, not just do visits. We are at the next step, the steps to fully implement OBQI. We'll get started. A couple of things before we move on to how to fully implement the OBQI. Jason with Centers for Mobility just arrived. He's the big, tall guy over there. Stand up, Jason, please. He'll be the one caring directly for your patient. Another thing, I was corrected just earlier. The PACOS program. I heard, I'm going to talk to Arnie because I got this from Arnie just 2 months ago. So I'm going to go, Arnie, listen, man, you gave me some wrong information. I got mud in my face. But Shala with minor said that did not pass. So you don't have to worry about that, okay? Phew, that's one less headache for you to deal with. All right. Steps to fully implement the OBQI. So you get the report. You get the report. By the way, what do you guys do with the report? That's the problem. It's like, oh no, what is this? Throw it out with a credit card application. All right, something has to be done with the report. The first thing that has to be done, you have to interpret it. This is a very simple one. We'll go through these steps more in details. Okay, this slide actually gives you a snapshot of the phases that needs to take place. And as I read and studied the manual that I showed you earlier, it says don't skip any of the steps. It really helps. All right. Then you select from that report as you interpret it, then you select target outcomes. After you select the target outcomes, you investigate the processes that contributed to those outcomes. Then you write the statement of problems or strengths. Why is this happening? And this number 4, the writing of the statement, may have to be periodically audited and changed, depending on how you're progressing with the process. A good statement of a problem will help you develop a best practice to solve that target outcome. That's why I said don't skip. Then you develop action strategies that will dictate and guide your actions as an agency for the following year. And of course, number 7, if you don't do number 7, you just wasted 1 to 6. You have to continue monitoring. What you're doing as an agency is, especially if you get an outcome report that has a lot of deficiencies, you tackle a couple things, 1 or 2 things at a time for 1 year. Then you develop processes for that. And you strengthen that area. Then the following year, you should be better in that area. Following year, you choose on another 1 or 2. And after a few years, you've already developed processes. Not hit and miss things, but processes to help you provide better patient care, which produces outcomes. Okay? All right. So, interpreting patient outcomes. This funny things happen when you get these reports. First thing that happens is a river in Egypt. What's a river in Egypt? Denial. You have denial that happens. Not my agency. There's absolutely no way this can be happening. Oh no, it must be the process. They're not, how can they compare me to an agency in Oregon? They have different patients over there. They have risk adjustments. They are incredible statisticians. They've considered all those factors and given you a report card based on what you deserve. Okay? I said this earlier, basically the outcome report is your report card for that previous year. The outcome report, the OBQI outcome report, takes 37 outcome measures. It's in, when you print it out, hopefully you guys are going to print out the OBQI manuals. Okay, I haven't said that, but please print them out. You'll see all those outcome measures on table 2.1. This report will aid you. It's an incredible tool to determine what your staffing needs will be. You may not be properly staffed. You may have nurses and clinicians that are not expertise in what you need to be doing for that year. Or they may not be properly trained. Your outcome reports will tell you what you need to focus on, how to train your staff. And the last, it'll give you a direction for that following year, like I said earlier. Basically, in interpreting the outcome reports, all you're saying is, we excelled here, we were deficient here. That's all. It's really simple, okay? And there are 2 different kinds of outcome reports. There's the end result outcomes, which focuses on the functional and clinical changes of a patient. And then there's the utilization outcomes. Did they go to the ER? Were they re-hospitalized? Were they discharged to the community? Did they go to an outpatient clinic? Very, very simple. But you can't just throw those reports away. You got to do something about it. Can you imagine your child coming home and say, oh, this is my report card? Oh yeah, throw it away. Don't worry about it. What do you think they're going to be for the following year? Still doing the same thing. Still making bad grades. All right. Selecting target outcomes. All right, who should do this? Who should select the target outcomes? Because this will guide what you do for the coming year. The management team, the administrator, the director of nursing, those people who are the head of your company should determine how or what target outcomes should be chosen for that coming year. In choosing the target outcomes, don't do more than 2. 2 will actually keep you very busy. 2 outcomes at a time. And if you want, you can just do 1. And also, when you choose the target outcomes, as you're comparing the graphs, the percentages, look at the sample size. I mean, if you're 50% deficient in one area, but the sample size is only 2, it's not really a big deal, right? But if you're 50% deficient in one area and your sample size was 10,000, you got a problem. Okay? Don't just look at the percentage, look at the sample size as well. I would also choose the relevance to agency goals. If your company focuses a lot on a specific patient population, I know of an agency that only deals with acute surgical patients, orthopedic patients. They shouldn't have to worry about Parkinson's patients. They shouldn't worry about neurological patients. They need to focus on those orthopedic cases, the outcomes that measures the orthopedic cases that they have. Is that making sense? Okay. And the clinical significance. What kind of quality of care were you providing? I mean, is it even an area that you want to deal with? To choose the target outcomes no more than 2 weeks after that target outcome report arrives. I mean, that outcome report arrives. No more than 2 weeks. Don't sit on that. Do something about it. Outcome investigation. All right, so you've done the selection of the target outcomes. Now you got to investigate what caused this deficiency. And you agency administrators, I imagine you'll probably be moderating these meetings. You should know that everyone who was involved with that target outcome needs to be in these meetings. From you, if you're involved in it, all the way to the home health aide, if they were involved with the target outcome. Everybody. The reason why is because in order to change it, they need to change. And in order for them to change, they have to understand why they're changing it. Also, no pointing fingers. If you know that you're not very tactful, please assign somebody else to do it. Because remember, you're investigating. You don't want your staff lying to you. You want to get the full truth when it comes to investigating these target outcomes. Also, I found it very helpful when you empower your staff, when you involve them in certain planning. I find that the loyalty that you have, you guys, I find the loyalty that you get from your staff when you say, listen, you are responsible for this. I mean, it goes a long way. They'll never leave you. Why do you think I've been with Rudy for 20-something years? He empowered me to do certain things. All right. Investigation. All right. In this part, you identify the agency patterns causing the area of deficiency. I said that before. What could they be? It could be somebody's not completing your OASIS properly. The OASIS is a very time-consuming tool, but it can be done right. And if it's done right, then the care can proceed well after that. Could it be that your frontline staff, the clinicians that are seeing your patients, are not getting the information on the OASIS? A lot of times, like I said earlier, we're going in blindfolded before we see the patients. That could be one of the problems. You got to investigate. Is that happening in your agency? It could be that, like I said, your equipment was ordered late. There was a, thanks George. That ought to do. There was an agency that called me this week and said, Joey, listen, I've noticed that one of your staff is very late in providing their care. Not late as in the time, but actually not aggressive early on in the plan of care. And I'm noticing that my orthopedic cases are not getting better as fast as I want them to be. Can you speak to your staff about being more aggressive earlier in the plan of care? I thought it was great. I mean, before we started doing this, I would have been defensive. Now I was like, absolutely, of course. That's what we're looking at. What processes do you have? It could be that you have a staff member that is just a really, really bad clinician. I mean, if you audit a chart and you see that patients are falling that you're following, and then you start auditing the chart and it shows that it's the same therapist doing it over and over again. You know, you see that George Katz is seeing your patients that are falling over and over again, and the patients that are not falling is being followed by Joey Ricafrente. You want to make sure to give them to Joey. I'm telling you what, I give George such a hard time, but I tell you, he's a good friend of mine, and if my parents needed a therapist, it'd be him. It'd be him. Sorry, Rudy, but it'd be George. All right. You may have, in doing this phase, you may already have certain QI programs that will help you do the investigation. Use them. If you don't, create processes to do some investigations. By the way, chart auditing is going to be really key in this phase. And it is not the kind of chart auditing that you guys are doing. I've done your chart audits. They are not outcome-based. They look like, was the patient evaluated? Did the doctor sign the orders? How many times were they seen? Those will not produce this kind of investigation. They do not follow this, which means that you have to develop a chart audit tool. We're actually developing one, okay, to help with this. All right. The next step, like I said earlier, I'm very visual. And by way of review, you have your report, you identify your outcomes, you determine your area of problems and strengths, and now you have to write down your problem statement. Like I said earlier, a well-written problem statement will direct your best practice for that target outcome. Sorry. All right. Problem statement. Be clear and concise with your wording. You are not Hemingway. No creative writing. Be clear and straight to the point. Describe the aspects of care that shows inadequacy, or in some cases, superiority. What did you excel in? What did you fail in? Address the issues only within your agency's control. Okay? Don't start dealing with issues, well, it's their fault, yeah, it's a problem, it's their fault. Forget about that. It's only what you guys can control. Okay? And make sure that as you write these problem statements, that you narrow the emphasis to a size that you guys can manage. Don't bite off more than you can chew. You're not solving world peace, you're just addressing your target outcome. Okay, make it simple, straight to the point. An example of a problem statement would be like this. In patients who are at risk for falls, there is no standardized assessment and no focus to improve safety. It's that simple. What is the problem of the falls? Well, this is a problem. No standardized assessment for improving. No standardized assessment and focus to improve safety. Here's another one. For patients with CHF, there is no tangible evidence of consistent assessment and patient training on CHF-related symptoms. You're going to be hearing me use CHF a lot because CHF is the #1 diagnosis that's rehospitalized. So we'll be talking a lot about CHF. Does that make sense? Okay. All right. All right, and then you have the best practice. The best practice statements identifies how, when, and what the clinician should do as it addresses those target outcomes. How, when, and what. It describes the aspects of care that you should improve on. There are 3 parts to a best practice statement. You have to address the assessment part, the care planning part, and coordination. When you do a best practice, when you're trying to improve patient care, you have to do it during the assessment. You have to write something for the assessment, okay? You have to write something that will guide your care planning. And of course, there has to be coordination between your staff that's seeing the patient that will help you produce those positive target outcomes. A good assessment practice statement will look like this. Patient family will be instructed on how to monitor CHF exacerbation signs and symptoms. They will be tested on the information every visit and given CHF sheet, information sheet. Simple, okay? But you have to tell your staff what those best practices. During the care planning phase, you can say that the RN will call the patient daily. You don't have to make the visit. The RN will call patient daily to receive the report from the patient and our family on what the signs and symptoms of CHF is for them that day. You don't have to, I mean, it's simple. Think about it. You've already taught them at the assessment what they're supposed to be looking for. And if you're trying to reduce the rehospitalization rate for CHF, you want more monitoring. Well, a phone call helps you monitor that. You don't have to go out there. And coordination. All related staff seeing that patient will be required to know CHF exacerbation signs and symptoms, and the CHF info sheet will be reviewed by all attending staff with the patient and family. So now what you've done is you have involved everybody involved in that care of that patient, doing what they're supposed to be doing, monitoring the CHF signs for that patient. Any questions on that? Making sense? Hopefully? Well, if you have any questions, write it down. We'll talk about it later. Okay. All right, developing the plan of action. All right. The steps again. You have the you have the outcome report comes in. You identify the target outcomes. Okay. You you interpret the target outcomes. Then you select the target outcomes. Then you investigate. You write the statement of problems. You develop the best practice. And now you have to develop the action strategies. Let's make this a group activity. All right. Let's choose CHF as still the problem. It's the topic. The title of the target outcome. We have a problem of CHF being a problem in your agency. We have a problem of CHF being the #1 rehospitalization diagnosis for your company. Give me a title of that target outcome. What do you want to produce? What do you want to happen? Anybody? Anybody? Exactly. Exactly. Preventing preventing readmission of patient with CHF. Okay. All right. Clear statement of the problem strengths. What do you guys think produces this outcome, this negative outcome in patients? What are you guys doing? Do you think what is happening in your agencies that's making CHF a high rate of rehospitalization for your company? Huh?
Not monitoring fluid balance.
Not monitoring fluid balance. What else? Not enough teaching. What else? Huh? Medication. Okay. I like, I'm sorry? The signs and symptoms. They don't know the signs and symptoms. They gain weight gain. Simple as that, weight gain. You're looking at your legs. I mean, patient does not know. Okay? So, all right. I'm sorry? Lazy. You know what, George? I actually have that. Laziness. They're just sitting around, eating bonbons. and the staff and the clinicians aren't doing anything about it. For the problems that you just came up with, what barriers do you think exist that prevents that from being addressed?
They can't pay for their beds,
Yep,
they don't have a scale,
yep,
they're lazy,
yep,
they don't want to get up and weigh
yep.
themselves every day.
There you go. Huh?
Ability for the patient to be taught.
The ability for the patient to be taught? Okay, maybe there's not a caregiver there, or if there is, that you guys aren't training them. Think about this. You guys have problems with CHF, right? Has anybody done these things? Has anybody addressed these things with patients? I'm seeing that ahead. I'm seeing some going no. I'm seeing some that are just not even thinking about it. I mean, no. I have not thought about it. I'm sorry. But these are things to deal with. This is how we need to start thinking. Okay. Action strategies. Okay, so you have the clear statement of the problem. You have identified the barriers. What now do you think you should be doing?
Set goals,
Set goals? Train staff? Give handouts? If your staff is not trained, send them to CEU classes. Your case conference forms should probably include CHF in there. If they don't. Okay? All right. In the action strategy, you have to also assign people to monitor that. Who's responsible for setting those action strategies? And in the review and monitoring of the plan, that, and go back to this, they suggest, by the way, they suggest that the statement, writing the problem statement should be done within 2 weeks, 2 to 3 weeks. Developing the best practice a week after that. Developing the action strategy no more than a month from the time that you receive the outcome report. Okay. And then you have the monitoring. They suggest that you have clinical record audits, 15 of your charts every 5 weeks at the beginning, 15 more at 7 weeks, and then 20 a month after that. This is a lot of chart auditing. They're recommending that. It's the only way you can see if your staff is doing what they're supposed to be doing consistently. Of course, if your agency is smaller, you pare it down a little bit, okay? All right. This is what an OBQI case conference looks like. I know the old model for case conferences has it where you have the team leader and everybody else is down here. And the team leader tells what everybody else has to do. Actually, what it really looks like is that we get a fax from you guys saying what you did on the case conference. We who are providing the care don't get any input on the patient care. Doesn't make sense, but that's the reality. That's what's happening. That's got to change. The way this works is this. The team leader is the conduit of information for everybody. The team leader will have all the evaluations from the RN, from the OT, from the PT, all the goals. And the team leader reminds these disciplines what they need to talk about. In fact, in the next page, it'll tell you like this. In the next page, it'll tell you the points of discussion that will govern the case conferences. All right? Is the care plan skilled? How are you approaching the goals? Are you getting closer to the goals? If there are any information that needs to be passed from one discipline to the next, the team leader will dictate, I can take care of that for you, or I can hook you two up together. Okay? Now, I know one of the challenges for doing case conferences, you have poor attendance. It's hard to get us in there. Our schedules are awful. There's no way. You plan one for 2 o'clock in the afternoon and we don't get there. We noticed that. Here's the coolest thing that happened to us just recently. So you know that we're developing a software program for the iPad. And by the way, it's already done. We're about to start playing with it next week. we decided to go ahead and buy the iPads. We kind of delayed a little bit, but about 2 months ago, 1 month ago, 2 months ago, decided to go ahead and buy 42 iPads. So what we're going to need. Well, we get to the Apple store and they said, sorry, we're out of the iPad 1. We were going to try to save money and pay $300 for them. Yeah, we're out of the iPad 1. You have to buy the iPad 2. We now have to be up another $100, right? $400 per unit. Boy, were we upset. I mean, that was costing us a lot of money. Ray's laughing at us. But yeah, it happened. So we started looking, George and I started studying the OBQI manuals, and we thought, case conferences, hold on a second. The iPad 2 has a camera. We can download Skype. You can download Skype. We can do case conferences off-site. It's unbelievable. We're like, this is amazing. So you can even shut off the video if I didn't watch myself. But it is something that can happen. And if you absolutely have to have all 4 people or every discipline that's up there, then you have to insist. You got to get Skype. Skype, by the way, is free. It's a free application. Doesn't cost anything. I just spoke to my son in the Philippines using Skype. So you can create a case conference off-site. Okay? We're going to be doing that with you guys, by the way. All right. So, any questions on the OBQI? You got to follow these steps, guys. It's really important. One of the questions to start asking too is, who will be conducting these different phases? Chart reviews are going to be hard to do. I understand that. And they're going to be very unique chart reviews. You either have to develop a program for within your company, or you have to ask somebody else to help you with that. Even some of these phases, let's see. Even selecting the target outcomes, developing the best practice. It's recommended when you develop the best practice that you include a rehab, especially if it's rehab related, you include one of your rehab employees or clinicians to be part of this. You form teams. This is not done by Mr. Administrator, Miss Administrator. You form teams within your company to go through the phases that I talked about, to go through those steps. You don't do it yourself. If you don't empower your staff, these changes are not going to be done. Okay? All right. Then we go to surge. I like the surge. I thank Arnie for the surge. The last time we talked, the way we presented this was really complicated. We even gave you forms on how to do it. I'm asking you now to throw away those forms. We're going to do it differently. We realized, okay, that didn't work. Let's see if we can present this in a different way. What a search is that it creates clinical expectations. It is a tool to determine the appropriate level of care for all disciplines upon admit. Upon admit. It identifies the areas of deficits and clinical concerns. And this last part, and I know I've harped on this enough, that the frontline clinicians need to have the information before they see the patient. Search protocol. All right. Clinical profile of a patient. And I know you people that have done admits, you've seen this before. I'm going to ask you to do a couple of things. On 1810 to 1860, right beside it, write down OT. For 1240, right beside pain assessment, write down RN, OT, PT. For shortness of breath, write down RN, OT, PT. Incontinence, the same. Pressure ulcers, the same, RN, OT, PT. Surgical wound, RN, OT, PT. Oral meds, RN, OT. Injectable meds, RN, OT, and of course, we've already assigned it for these functional areas. The reason I had you write those in is because those different scores, depending on what scores they get on these different MOs, will determine whether you need an OT to address that, a PT, an RN, or speech or whatever. Okay? So if you have an area where the patient needs assistance in, you have to consider those disciplines that I gave you to start asking for those service. Okay? All right. Next. This is a tool that we're going to use to help come up with developing a plan of care that properly utilizes services and the level of services. DUB obviously is dressing upper body. DLB is dressing lower body. BATH is, I'm just joking. TT is toileting. TH is toilet hygiene. They're Dutch. And TT stands for something in Holland. Anyway, transfer and then gate is the last. When we use this tool, the first thing that we do is address gate. That's the first thing that we address is gate. The reason why is having a picture of what gait is gives us the most immediate snapshot of the level of functionality of that patient. Gives us the best snapshot, okay? The next page are just MO scores. As we do this workshop, you're going to need this page. We're going to keep flipping back and forth to this, okay? Moving on. Okay. Demo case. We're going to practice a couple of cases, and then we're going to have you guys work on yours. All right, here's a demo case. This is an actual patient, by the way. Actual patient, actual care that was given to this patient. Okay. Starter care, 5411. Patient is 82 years old. Went into the hospital because of COPD. Just came out of the hospital, went home. At home, has no caregiver. No pain, moderate SOB with moderate exertion, is incontinent, no surgical wounds, no bed sores, no, they need some setup with meds, a little bit of, they're independent, but they just need help with setup, and no injectable meds. The nurse goes out, admits the patient, and assigns these numbers to the patient. Actual case. Dressing upper body is a 0. What is a 0? Independent. Okay. Oh, by the way, look down here. Before the patient was hospitalized for COPD, they were independent in all areas. Okay. Just be aware of that. Dressing lower body, they were at a 2. Bathing, they were at a 3. What is I know you guys are flipping. What is a 2? Assistance to dress up, okay. All right. A 3 for bathing is they participate with bathing, but needs assistance. That's actually in the shower or bathtub. Okay. Toileting, toilet hygiene, no problems. Transfer is a 1, which makes it just minimal assist, or they may just need a bedside commode, a 3-in-1 bedside commode. Okay. And then gate is a 2, which makes it they are using a 2-handed device, or they may need assistance from another. They could be modified independent, think about that, okay? Or they may need assistance from another. Here is the actual plan of care that was set by the admitting nurse. Would you guys have done that? I hear people laughing. No. Okay, but we'll work through this. All right? So the nurse was out there all 60 days. 60 days. She went in for COPD. She goes out, the patient went in for 60 days. The patient went in for COPD, and the nurse sees for 60 days. PT, 3-week 2. What was the score for PT for gait? Is a 2. They're already modified independent. By the way, modified to CMS, modified independent is independent. Okay, you should know that. All right. The OT, hold on a second. DLB, dressing lower body is a 2, bathing is a 3, transfer is a 1, no OT. And home health aid, 3 week 4, 2 week 4. This would be a good time to tell you guys, by the way, CMS thinks that you guys make a lot of money. You know why? Because you are providing care, you are providing a free service. Home health aid visits have not been reimbursed since 2000. And you guys continue to provide it. They're saying you're making way too much money. That's why they're pulling the money out. All right. So what do you think? What would be an efficient plan of care? I'll write this down. For RN, your RNs, how many times would you see the patient and how long? I hear 2 week 2 for the first 2 weeks. What would you be doing with the patient? Go to the clinical profile. What problems do they have? Shortness of breath with moderate exertion. Would you give them a handout on breathing techniques? Yeah, I would. Pardon me? Medication teaching?
Energy conservation teaching.
Ma'am?
80% of CMPDs go back to the hospital within 2 weeks.
There,
So you're going to high end at the very front.
okay.
To keep them out of the hospital, you get them on track. So I would do like a 3 week, 1, 2 week, 1, and then see where we're at there and evaluate.
Did you guys hear that? A 3 week one and then taper down to 2 week one? Any disagreements? So it makes sense. All right. We'll do 3 week 1 and then 2 week 1. And then we'll stop for that. What about PT? Is 3 week 2 necessary for PT? They're already modified independent. Their transfers are, they're either using an assistive device or they're independent. But basically they're independent. PTs. There's 2 PTs over here. What would you ask for? About 2 week 2? 2 week 2. OT, the star of the show. OT. What would you ask for? Huh? 2 week 3? 2 week 4? Two week 3? Okay, let's look at the case again. All right. The score is a 3 on bathing. What is a 3? Needs assistance or supervision at all times. What is the most dangerous part of the house? The shower. Exactly, the shower. I actually would even increase that. I probably would even ask for like a 2 week 5 for the patient. For OT. Probably increase that. Okay. Not only that, but they have other areas to cover. Lower body. Transfers. Okay, so 2 week 5 on the patient. Home health aid. How long will you have the home health aid go out there?
Until OT says it's open.
Thank you. Thank you. I love that. Please, until the OT says the goals are met. So, Miss Smith, I tell you what, while we're doing this care, because we want you to be independent again, while we're doing this care, we're going to send you, because we're really nice people, we're going to send you a home health aide to take care of your needs while the OT is there. So we'll ask for the OT to be out, for the home health aide to be out there, let's say 2 week 5. We'll do the home health aide for 2 week 5. Make sense? Is that okay with everybody? Go to the next page. Somebody get a calculator ready, please. All right. The actual. You had 18 RN visits. But how much do you guys pay your nurses? I don't know.
A lot.
A lot? Is it a lot more than the 15 that I just wrote down? Okay. All right. So this is a conservative figure. Okay. RN, $50 a visit, costs $900 for 18 visits. The PT, $6 a visit for 85 visits. I mean, $6 visits for $85 a visit.
$6 a visit, I'll take it.
Yeah. Yeah. They're going, I heard that. The OT, no visits. And the home health aides, 20 visits at, how much do you guys pay? $20 a visit? Are you serious? Goodness gracious. Okay, let's say $400. So basically, because of that figure, you guys just made $40. You made $40 for that episode. No wonder you guys keep asking us to do 14 visits. All right, so let's go through what we decided as a group. The RN, 3 week 1, 2 week 1. So how many visits? 5 visits? We're still going to keep the $50, so that's $250. The PT, 4 visits times 85. Who's good with math? 340. The OT is 10 visits at 85, so 850. Okay, and the home health aide is 10 visits at 20. Okay, all right, so 200. Somebody add that up. $250, huh? 1840. Is that right? 1840? So you have 250, 340, 850, 200. 1840. Okay. 1640. 1640. All right. 1640. The first one, remember only 6 rehab visits was done, so you guys were reimbursed about $1,800 for 6 rehab visits. The next one, our plan of care, you have 14 visits that was done. What's your reimbursement for 14 visits? Where's that chart? Reimbursement for 14 visits is about $3,600, $3,700? Okay, $3,700. All right. $3,700 minus $1,840 equals okay, I'm sorry. 30. What is it? 3,700 minus 1,840 is 16. I'm sorry. 1,640 is about $2,100, right? Or 2060. 2060 versus $40. And you provided the proper care for that patient. Is this starting to add up well for you guys? Is it starting to make sense? I've got the people going, what? When you find an RN, or when you find any clinicians, actually admit can be done by an RN, a PT, or a speech therapist. If you find a clinician that can do an incredible admit, pay them gold. They're worth their weight in gold. Because you have some admitting nurses that are just flying through these admits and just writing figures just to get through. And if you don't do it right at the very beginning, the whole process fails. It all falls. But your money is made at the admit. Right?
So how can we train the RN admin on how to see the patient on the eye of the PT and the eye of the
It's not. You see, what we just did, in this room you have RNs, PTs, and OTs. And we agreed as a group that this is what we would have done. In fact, some of you guys are already asking us to do this. Except for the RNs, the RN visits, some of you guys are already asking us, when you go out there, make sure, see what the OT needs. They need OT. And in our minds, even though we don't set the plan of care for the OT, we're already going, yeah, the OT's probably going to be there about 2-3 weeks. And sure enough, when Chris goes out there and does an admit, or her admit, that it's about the same. I see a hand. Yeah, and that's a very, very good question. And
We should go already as a physical therapy. You have to put the ADLs in all these. You send small snap. But we as the nurses, we still have clinical things that we have to do. So how are you going to connect those two together?
the question is, there are still nursing needs. Say we meet our goals as therapists. There are still some nursing needs, a need for nurses to be out there. What dictates that is your OASIS scores. And when you do the surge and you have the OASIS scores with you, and you do the OBQI, and you do monitoring all throughout the care, then it should dictate how much service that you have. In fact, this is the way it works. If a surveyor goes out, they don't see the patient through your eyes. They see this, what you guys are documenting. And they grade you, they deny you, or they approve you based on what you guys are documenting. Does that make sense? The question is, the comment is, we have different clinical eyes, and you guys have different clinical eyes. I mean, we don't look at patients the same way. Am I? Right.
So how are we going to work together with that?
Do you remember what I said earlier? When it comes to the OBQI, right? When it comes to communication, right? What we have is what you guys give us. If we have your scores from the admit, we have that. We come out, much like what happens in the hospital. We come out and give you a status of that patient. Then we can make amendments to the plan of care. We don't have to stick to what we wrote initially, but we can make changes as it's needed. The problem is we're not communicating at all. That's why we're not making those amendments. You say our eyes are different, our clinical eyes are different. What actually makes it the same are the MOS scores. There is no room for interpretation with the MOS. Look, you go see a patient like this patient. They were using a two-handed device and/or assistance from another. They're a number 2. There's no way to mistake that. They're not using a cane, or they may be needing an assistance from another person. The MOS course connects our eyes. You guys know what the MOS scores are? Okay. These right here, this page.
What I'm saying, does the agency send you the scores?
No, that's the problem. You don't send us the scores. We don't know what the patient looks like when we see the patient. It's completely different. But again, going back to the surveyors, if you're surveyed, the surveyors only sees that patient chart and how your nurse admitted the patient and the scores that were assigned. That's all. You don't get to say, oh, I thought they kind of looked like this, or I felt they looked like this. No, you can't write that down. You have to write concrete numbers. All right, let's go to the next case. Believe me, I understand this will cause a lot of scratching your heads. But the more you do it, the easier it gets. All right, so we have another case. And Ray, I know about the comorbidity. I understand that, but it should also be reflected on the MOS scores. Okay. All right. Real case again. 68-year-old person had a recent femoral fracture. Was just admitted to. Discharged from SNF. By the way, If they were discharged from SNF, what should that tell you about the rehab? They've already had therapy, okay? And when a surveyor looks at a patient, they're looking at where the patient came from, what the standard of care was at that facility or that level, that care continuum. Okay, so they know when we see the patient that came from SNF, they've already had therapy. Okay, that should influence what we do as well. They go home with a caregiver, their pain is 4 out of 10, there's no shortness of breath, they are also incontinent, no bed sores, no surgical wounds, they need just reminders with their oral meds and no injectable meds. Okay, now the caregiver, why should this be important in this case? You can teach, yes. You can teach them everything that you're going to be doing with them. It needs to be part of the plan of care. The pain management, the meds, the vital signs, all that stuff. Safety. Okay, the nurse admits the patient, and this was their functional score. Dressing upper body as a 1, lower body as a 2, bathing is a 3. What's a 3 bathing? Okay. All right. Toileting is a 1. Transfer is a 1. Gait, as you might have guessed, is a 3, and it's a weight bearing is tolerated. They were also independent with ADLs, everything at home prior to the fall and the fracture. All right. This is what the nurse did. 2 week 2, 1 week 7. Again, had to stay there for the whole entire 60 days. Would you agree with what the nurse did? Thank you. They need help with meds. They've got pain, so you know that's an area that you need to cover. They don't have any respiratory issues. They are incontinent. You know what? There are probably no more wounds, right? There are no more wounds, but there's still some issues here. How much nursing care would you ask for at that point? What do you? Okay, I hear 3 times a week for teaching. What are you going to be teaching them?
No, I said at least 3 weeks of teaching.
3 weeks of teaching. What are you going to be teaching them?
Education and
Medication? Do you see, you have the caregiver now.
okay.
You have a caregiver here. Are you going to need really 3 weeks of teaching nursing care?
Well, it depends on the ability of the caregiver too.
Okay, it depends on the caregiver. That's a good point. Okay. Yes, ma'am.
I probably do 1 week too.
1 week.
Because during your admission, you're just going to teach anyway. You're going to find out the problems. You're already going to start teaching them. The second one is to follow up to see if they're going to be adherent to those. And then after that, if they're not going to be adherent, then you're going to have to add more.
Yeah. Yeah. You can get a lot of things done at the very, very beginning. Let's play it safe. We're gonna take a combination of the two. The average will be 2 times a week for 2 weeks. Can we do that?
Yeah.
Okay. Would that be okay with everybody? I see we lost some people. I told you this stuff was fun, but it's also very complicated. All right. PT 2 week 8. Are you serious? Yes, ma'am.
The frequency now, who is what developing the frequency or the PT when you go out to be evaluated?
Your frequency is going to be based on the MOST course. That's what we're doing right now. So you have to start thinking like the admitting nurse or the admitting clinician. What we're actually, the recommendation is that the admitting person is setting these levels. And I see people going, no way. Okay, here's the thing. These plan of care can be amended when the therapist goes out there.
Okay, so what about the eval and treat?
In the hospitals, there are no such things as eval and treat.
No, she's talking about when the RNs
I
are
mean, when the
already
RN go out,
When the RN goes out and what?
and then can write a PT to
No. No more. You know what? I'd love to see Evalin treats. I love it. But it doesn't follow what they're wanting us to do. They want us to be focused from your admit. They want us to be focused on that patient care.
Yeah, what about the doctor already wrote the frequency?
Okay. Very, very, very good point. Because I get doctor's orders a lot of times. The doctor wants you to see the patient 3 week 4. And I see the patient, they're already independent. I call the doctor, or you guys can call the doctor, whatever, and tell them, look, doc, according to CMS guidelines, I can't see your patients anymore. The doctors don't dictate. Here's the way, somebody asked me this. This is me, this is the doctor, this is CMS. I follow the rules. I need the doctor's orders to cover my visits, but I need to follow their rules. Okay? It's the way it works. I know this is kind of scary because this is unknown grounds here. But again, I'm telling you that this is being used in Oregon, this is being used all over the United States, and people are thriving as a result of it. The question that Ray had for me earlier is, how do we put these things together? Okay? The admit happens, and you guys go on the limb, you admitting nurses or therapists or speech therapists, go on the limb and make these recommendations. You really go on the limb, okay? But what covers you is what happens afterwards. Communication, outcome-based quality improvement case conferences. You have to get weekly reports. All these things have to take place. If you don't do the two in conjunction, it's not going to work. Yes, ma'am.
With the new rules of the 13th visit and the 20th visit rebound, for a nurse going out there doing it, setting this up, should we set it up within that 2-week period, or should we set it up for the entire 60 days?
If you think, don't even look at those reassessment rules in setting the plan of care. If you have a patient that absolutely needs 22 visits, ask for it. Okay?
Here's the problem, right?
Complete cert period, yes.
Okay, the problem being for us is on that, the one where it says how many therapies you're going to do is what is based on what we pay. If you don't do those amount of therapies, then we end up paying back and they take that money back.
They take some of it back.
Yes.
Right, I understand. And I know it's a challenge for you guys, but realize this. If we cannot justify doing those visits to reach those certain thresholds, you're going to get denied anyway. I mean, we can only make a professional judgment, but it is not an exact science. We want you guys to that's why we're doing this. We want you guys to make money. But we can't just not follow the rules to get that. Okay? All right. So PT is not going to be 2 week 8. If I was a PT, going back to an earlier concern, I'm sorry. Going back to an earlier concern. Like I said, you guys are already asking us to a certain extent to do this. If you have a problem doing it, send us your MO scores, we'll do it for you. Is that a leap or what? I know. But it's got to get started somehow. We'll do it for you. As long as your admit is very thorough. It has to be thorough. If it's not thorough, don't send it to us. Please. Okay? All right. PT, 2 week 8, no. PT will probably be, what do you got, PT? Yes, sir. 2 week 3. OT, 1 week 2. OT, 1 week 2. OT, Miss OT, yes. What is it? What is it? What do you need? You got dressing problems, bathing problems, transfer problems, toileting problems. They were independent before they went to the hospital.
So at least 2 weeks.
To be, and I'm hearing 2 week 4. I'm leaning towards 2 week 4. Okay. Home health aid, 3 week 9. I'm going to go into the home health aid business. I'm telling you, $20 a visit. That's pretty good. 3 week 9. Would you do 3-week 9? No, you follow the OT, 2-week 4. And if I were you, I would say you go on this date and the OT will go on separate dates. Coordinate that so the patient gets at least bathed 4 days out of the week. Okay? All right, somebody add that up for me. Whatever it is, it's going to be really, really bad. On the left side, the actual plan of care, the efficient plan of care will save you a lot of money, will get you a lot of money. Okay. We don't have to go any further with this. I think you guys are understanding what's happening now. Okay? The demo, you guys should take back with you. You administrators, take back with you, practice it. If you choose to follow this, practice it in your agencies. Okay? Thanks for coming, folks. We'll be around to answer some of your individualized questions.